Welcome, everyone. I'm going to give us just another minute or so to give everybody a chance to join before we get started. Okay, well, thank you all so much for being here. Welcome to our October webinar. Before we jump into today's presentation, I am just going to run through a couple of reminders and announcements for everybody. So first, I do want to let you know that there is an option at the bottom of your screen to turn on captions. If that would be helpful for you, you'll see a little icon that says CC, and you can click that to turn those on. There's also a Q&A feature at the bottom of your screen, and throughout the presentation, we would love for you to submit any questions you have, and our presenters will be answering those questions toward the end of today's webinar. So please submit those questions. You can do that anytime during the presentation. And then we just want to give a disclaimer that this educational session is not intended for the purpose of providing medical advice. Just a couple of announcements for you. If you have not heard yet, we recently moved our MSA Connect platform over to a brand new platform. You can sign up for that at missionmsaconnect.org. It's really great, got a lot of new features that we're really excited about, so we would love to see you in there. And then related to that, we are today launching a new volunteer opportunity that we're really excited about and would love for those of you who are interested to apply for. We are starting a Living with MSA advisory group, and that's open to patients and care partners. And it's just a way for us to really hear from people who are directly affected by MSA, and for you to kind of use your voice to be involved in the work that we're doing as an organization. So if you're interested in learning more and applying for that, you can do that by signing up for MSA Connect, and you'll see a volunteer tab in there. You can click that to see that volunteer opportunity and find the link to apply. And then finally, I would love to introduce our speakers for today's webinar. They are going to be walking you all through a presentation on autonomic dysfunction in MSA. And so we're so excited to have Dr. Lamotte and Dr. Virmani from the University of Utah and the University of Arkansas for Medical Sciences, respectively. They're both from Mission MSA Centers of Excellence. And so we, are really thankful they're here and excited about the presentation they're going to give. And I will pass it over to them now.
Thank you. Let me just load up the slides real quick. I think you should have access now.
Yeah. Good morning, everyone. So we will brief overview of the autonomic dysfunction that we see in people living with MSA. And that's really the goal of the webinar. So those are the three main objectives. One is to review what are the symptoms of autonomic dysfunction in MSA, and we'll explain the different terms here. Then we will discuss how we evaluate for signs of autonomic dysfunction in MSA. And finally, discuss some of the treatment of those symptoms, although it will be a brief overview of the treatment because it can be very complex. Oops. Yeah. So multiple system atrophy, as a brief introduction, is neurodegenerative disease. It's a progressive disease that affect, the brain and the nervous system, and it's characterized by what we call autonomic failure. So autonomic failure means that there is the system that control automatic function, such as blood pressure, heart rate regulation, bladder function, bowel movements, sexual function, is not working or not working properly. And you have to have a diagnosis of MSA. You have to have autonomic failure with motor symptoms, so things that we can see on the clinical examinations when you go to see a physician, which can be signs of Parkinson's, so slow movement, that's the MSA-P, or signs of cerebellar ataxia, so it's more difficulty with gait, balance, coordination of movement, and that's the MSA-C. So those are the two subtypes of multiple system atrophy. But to make a diagnosis of MSA, you really need to have that core feature of autonomic failure. Next slide here. So what is the autonomic nervous system? To think about it kind of simply, broad overview, think about anything that regulates automatic function. You don't have to think about those, but those things happen all the time in your body. So blood pressure, changes in blood pressure, heart rate, digestion, sweat, sexual function, bladder function, so peeing, urination, for example. So it's important to realize that dysfunction or impairment of the autonomic nervous system, those automatic function, happens at every stages of multiple system atrophy. And in many patients, it's actually the initial presentation. Those patients tell us, I started maybe passing out about 5 years ago. And then I developed issue with mobility, with movements. I started to have issue with bladder function. And then I started to develop motor symptoms. So sometimes the autonomic manifestations are the initial symptoms of multiple system atrophy. And as the disease progresses, those autonomic manifestations typically stay. They are there for the ride, for the long course. And they can progress. Someone can have very mild urinary dysfunction and eventually need to have a catheter, for example, or do self-catheterization to empty the bladder. It's important to know that there are no two patients with MSA that are the same. So really the manifestation of autonomic dysfunction in MSA are very variable. They need to be there to make the diagnosis, but each patient is different. Someone might be dealing with more blood pressure issue. Another one might be dealing with more bladder dysfunction or issue with emptying the bladder. It's also one of the challenging symptoms of MSA because really managing autonomic dysfunction really requires multiple specialists to work together. Can be your neurologist, a cardiologist that was involved potentially very early on for management of blood pressure, a urologist for management of bladder function or sexual dysfunction, a gastroenterologist for management of constipation and other issue with the gut in patients with MSA. Your primary care physician probably was the one who actually detected the issues with you first. And also, there is a very important role of rehabilitation specialists, such as physical therapists, nutritionists, speech therapists, etc. So the first part of the talk is going to focus on really blood pressure control in patients with MSA. So that's what we call cardiovascular autonomic dysfunction. So that means that anything that regulates the blood flow and the blood pressure is not working properly. And the hallmark of cardiovascular autonomic failure is what we called orthostatic hypotension. So orthostatic hypotension means that there is an excessive drop in blood pressure when you go from laying or sitting to standing. And there is specific criteria. We use the cutoff of a drop in 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic. If you drop more than that, it is abnormal. You have orthostatic hypotension. So why does that happen? So when you stand up, we all live on Earth. There is gravity, and you stand up, there is pooling of blood away from your heart, away from your head, and the blood pools in your leg, in the lower parts of your body, in the belly, in what we call the splanchnic vasculature, and in your legs. The brain hates that. The brain always needs blood flow. So it's going to trigger a reflex that release what we call norepinephrine that squeeze the blood vessel in your legs. So the blood vessels in your legs are squeezed and the blood goes back up. So that is why when you go from sitting or laying to standing, your blood pressure really should not drop significantly. That reflex that squeeze the blood vessel in your belly and in your legs to bring the blood flow back up is not working properly in most patients with MSA. Hence, you have a drop in blood pressure. If you have a drop in blood pressure, it can cause lack of blood flow to the brain and symptoms. We'll talk about those. So how frequent? I would say the majority of patients with MSA have orthostatic hypotension. Early on in the disease, it is possible that you can make a diagnosis of MSA without orthostatic hypotension. As the disease progresses, most, but not all, but most people living with MSA will have orthostatic hypotension. As you can imagine, if you have drop in blood pressure, then you can be dizzy, lightheaded, you can faint. And if you faint, you can fall, and it can increase your risk of breaking a bone. So it's fracture of your bone. It can increase your risk of going to the emergency room, being admitted to the hospital, going to a nursing home. And there is also a lot of data showing that the changes in blood pressure and changes of blood flow to the brain really increase the risk of dementia. So that's issue with memory and thinking processes, and also potentially the risk of a heart attack or kidney issues. So what are the symptoms of low blood pressure? Some of you on the call might have experienced those symptoms. The most common one would be if your blood pressure drops, you feel dizzy, right? So it's not necessarily the room spinning around you, that what we typically call vertigo, but it's more a general sensation of wooziness, lightheadedness, feeling that things are you're gonna faint. Sometimes the vision becomes blurry, become black. You feel weak. You just feel like you have drained of energy. There is a symptom of pain in the neck and in the shoulder called the coat hanger phenomenon. That's why there's a coat hanger on the slide. And it's really a reflection of lack of blood flow or lower blood flow to the muscles of the neck and the shoulder, which cause kind of a cramping and painful sensation. The triggers obviously is standing up, right? As we discussed, standing up pulls the blood in the lower part of your body. There is no squeezing reflex and the blood pressure drops. But there are other triggers that you should be aware of. One is meals. If you eat, guess where the blood goes? It goes to your gut, right? The body doesn't really care about your brain if you just ate a big meal, just want to digest and get the nutrients. So if there is shunting of blood to your gut, then the blood pressure might drop in some patients, even in the sitting position. That is called postprandial hypotension. Alcohol can vasodilate. It opens your blood vessel, and the pooling of blood is even stronger. So the blood pressure drops. Hot weather. A lot of patients with MSA, for different reasons, but don't really like the heat. And it's because it opens the blood vessel and worsens the drop in blood pressure. Dehydration is also a big one, and we'll talk about it a little bit more. Morning tends to be more challenging. In the morning hours, typically the blood pressure is lower, and that is related to how the body regulates blood volume at night, right? At night, you lay down, there's a lot of blood flow going to the brain. The brain doesn't really need that much blood flow at night. So there is a system, a mechanism that shunt that blood to the kidneys. The kidneys filter the blood, fill up the bladder. And that's why kind of the first thing we do, and sometimes some of you may actually go urinate at night. And the first thing we do in the morning, we empty the bladder. So we start the day by kind of losing some of the volume. And that is why the morning hours tends to be more challenging in terms of blood pressure control. How do we recognize it? I would say the history, talking to the patient, is how we typically have the clue that something is wrong with blood pressure. And really just taking blood pressure measurement in the clinic, and we do blood pressure and heart rate measurement in different positions. Ideally, we should do it laying and standing. But if you don't have a bed, for example, and you go to see your primary care and there's only a chair in the office, sometimes you can do sitting to standing and look at that difference in blood pressure. There are specific tests that can actually look at blood pressure control. It's called autonomic testing. Most centers in the US don't have an autonomic laboratory. And I would say it is really not necessary to make a diagnosis of orthostatic hypertension. It can be very helpful, but it is not necessary in most patients who have multiple system atrophy. How do we treat? And the first thing is education. Really, you see that bold red caption is we have the patient, they have to recognize what are the symptoms of orthostatic hypertension. Not only the lightheadedness, but maybe the pain in the neck and the shoulder, maybe the generalized fatigue when they stand up. That's a clue that say, hey, my blood pressure might be low here. I better sit down because I don't want to faint. The treatment is really the mainstay of treatments is, if we can, is to increase blood volume. So think about the blood vessel as a pipe. And I told you in multiple system atrophy, there's a lack of squeezing of those blood vessels. So you have an empty pipe, and if you squeeze an empty pipe, nothing is going back up. But now if you squeeze a pipe that is full of water and you squeeze it, the water is going to go back up. The water is going to go back to your heart, back to your brain. So that's the blood volume. The best way to increase blood volume is water and salt to some extent. So water, how much water? We typically at least recommend, 60, 80 ounces of water a day should be a goal, 2 to 3 liters, 1.5 to 3 liters. Salt is also important. And that might sound a little bit crazy, right? Because we tell everyone in the US to kind of stay away from salt because it can increase blood pressure. But again, salt is the sponge that's going to keep the water in those blood vessels. So you need the salt. If you just drink the water, it's going to get through your body, filter through the kidneys, and you're going to spend a lot of time in the restroom. So increasing salt is also important. How much salt? It's really depend on the patient, but typically we can push the salt pretty high in patients with MSA. Raising the head of the bed is also important. Remember, I told you that at night, there's a reflex, the mechanisms in the brain that really shunt a lot of blood volume to the kidneys. And by raising the head of the bed at night, you actually decrease that reflex. So the blood pressure in the mornings are typically better. It's also important because the blood pressure laying down in some patients with MSA is too high. It's the opposite. You have what we call supine hypertension. So you can have someone laying down with very high blood pressure and standing up with very low blood pressure. We focused on the low blood pressure so far, but the very high blood pressure can also be dangerous if it is too high. And when I say too high, those are, we are thinking about numbers in the 170s, 180s, 200, 220s. Those are dangerous numbers for the brain and for your body. And raising the head of the bed can actually help with what we call supine hypertension. Now, we try to tell patients to stay physically active, to move, and can be challenging if there is significant drop in blood pressure when they stand up. So some forms of exercise that can be done would be exercise where you are almost laying down or seated, right? So recumbent cycling, rowing. If you can do some exercise in the pool, if that's available to you, that can also be very helpful. The compressions stockings can be helpful. Now, I would start with a caveat is that the compression stockings that would go from your toe to your knees will not do much for your blood pressure. Those are pretty good if you have, to prevent clots in the veins, in the superficial vasculature. But we really need to compress is the belly and the thigh, the big muscles in your body. That's where the blood pools. By compressing it, you keep the blood above, close to the heart, close to the brain. So really the types of compression stockings that we would recommend would be the compression stockings that would go from your toes to your waist. I don't have to tell you, those are a pain to put on, and they can be very difficult to tolerate, especially in the heat, right? In the summer. So realistically, those are not too good for people living with MSA. However, the abdominal binder, so that's a Velcro binder that you put around your abdomen, can be extremely helpful. Most of the pooling of blood goes to the belly. It doesn't go to your legs, it goes to the belly. So if you have a compression around your belly, around your abdomen, with an abdominal binder that you put in the morning and remove in the evening, that can be really helpful. And finally, there are medications. In cases where there is a significant drop in blood pressure with symptoms that puts the patient at risk of fainting, we discuss medication, and often, in my experience, often the neurologist is the one managing those medications, sometimes cardiologist, depending on the centers where you go. But there are some pretty good medication that could, in some situation, be really helpful. But we will not go into the detail of those medication today. But there are two that are FDA approved, only two, right? Not a lot of options that are approved by the FDA. This is midodrine and droxidopa. And there are others that I've put on the slide, and there are many others that are not on the slide that sometimes are used to treat drop in blood pressure. You see at the bottom of the slide, I also said, be careful, don't forget about high blood pressure when you lay down. And sometimes we have to treat both. We have to treat the high blood pressure when someone lay down and at night, and the low blood pressure when someone stand up. Ideally, if you have the low blood pressure and we prescribe those medications to treat the low blood pressure, we don't want you to lay down during the day, right? Because those medications might still have an effect and might actually increase your blood pressure to dangerous level if you lay down. What about if you need to take a nap, if you need to rest? We would prefer, to go to a recliner, not completely laying flat, because those really, with those medication, you can really increase the risk of hypertension when you lay down. Okay, so that's now Dr. Virmani. You're going to talk about the urinary and sexual dysfunction. You're muted.
Sorry, so kind of moving on to the next section, we're going to talk about urinary dysfunction and sexual dysfunction, which are also very common, as Dr. Lamotte said, early in the disease and as the disease goes on. So this is just a diagram of kind of the anatomy of what our urinary tract looks like. The kidneys are producing urine by filtering the blood, and then that goes down through the ureters into a bladder, and then there's a muscle here that keeps our urine in the bladder, that when we're ready to go to the restroom, that gets released and we urinate out that urine. So there are two main categories of problems that can occur in bladder function. One is keeping the urine stored in the bladder. Sometimes the bladder muscle may relax involuntarily when we don't want it to, or some of the muscles may contract and cause us to lose urine when we don't want to. And then we can also have problems with emptying, where we are unable to completely empty the bladder, or there's difficulty getting the urine out because either the sphincter muscles are not relaxing enough or the bladder muscles are not contracting enough. And both of these are very highly regulated by what is called the autonomic nervous system, which is what we're talking about today. And this little caricature in the top kind of gives a diagram of what some of that control looks like, and we're not going to go into much detail about that today. I don't think even my medical students probably know much about that diagram in the top corner. So bladder dysfunction. So looking at urine storage dysfunction first. So what are the symptoms of that? So the symptoms of being unable to store your urine, as you might expect, are that you have increased frequency of urination. You need to keep going because you can't hold it in. You may have urgency develop, that you just have to go suddenly. Sometimes you may not be able to get to the restroom in time and may have accidents or urinary incontinence. So the opposite of that is emptying or voiding dysfunction. And so if you think of, again, our picture of the urinary system, now we're talking about maybe there's something that's blocking the output of the urethra, or that muscle here is not opening up to allow the liquid to go down and out, or the bladder is not contracting well enough to push the fluid out of that smaller opening that leads to our being able to void our urine. And this can lead to a weak stream or hesitancy. Maybe you start, you stop, you start, you stop, and you just can't get it all out. And eventually this can also lead to excess urine remaining in the bladder after we've gone to the bathroom. And that can have its own complications. So stuff is just sitting there, just like if you think of stagnant water sitting in, your pool or a lake. This can lead to a ground for bacteria to develop and can lead to infections. And also, if there's too much salt or other things in the urine, this can also lead to stones developing in the urine, which then can be painful to get out. If things start backing up the ureters back into the kidneys, then we can also start having problems with the ways the kidney filters urine. It can develop infection in the kidney if, again, this liquid, the urine, it gets infected and backs up into the kidney. And of course, frequent urination in this case can be because, again, you're not releasing as much as you need to completely empty your bladder. So again, maybe 30 minutes later or an hour later, you get that urge to go urinate because your bladder is still full. These are very common in multiple system atrophy. Over 90% of patients with the disease will have some form of bladder dysfunction, and very often it's the first manifestation or first symptoms that are noted. Because this is so common as we get older in any case, and MSA is also a disease of aging, or occurs more commonly as we get older. Sometimes patients may not get diagnosed with MSA, and this may be treated just as, someone with frequent urination and not get recognized as MSA for a period of time till other symptoms start developing, that now people start putting things together and say, hey, this is more than just problems with frequent urination or inability to urinate due to an obstruction. So about 60 to 70% of people with MSA will have inability to completely empty their bladder when they go to pee. About 50% will have daytime urinary frequency, but what's more of a problem and results in, poor sleep quality is almost 70% of people have nighttime urination frequency, where they're constantly getting up in the middle of the night to go to the bathroom. So how can we diagnose this? Again, as with other things in neurology, history is very important. Asking people about how things occur during the day and what causes some of the symptoms they're having can help us. There are questionnaires that can ask those specific questions if that makes it quicker and easier in a clinic visit, say, for example. And then a physical examination, especially if needed with the help of a urologist, can also be useful. Sometimes testing can help us. So we can test the urine to look for infection or signs of blood, which may suggest there's a obstruction to the outflow of the urine. We can do a scan or an ultrasound of the bladder to see if there's still urine left in the bladder after you've gone to the bathroom to pee out. Anything above 100 to 150 milliliters may suggest that you have incomplete bladder emptying left in the bladder. We can ask people to keep a diary so that they actually quantify how frequently they go to the restroom, how much urine output they get. You can pee into a cup with gradations, so you know exactly how much you're peeing out at every time, and also kind of document when it gets to the point where you're unable to control it at all and maybe have a accident or incontinence. And then with the help of the urologist, we can actually look at the different levels of function, how the bladder is functioning, how the outlet muscle is functioning, with the help of something called urodynamic testing, which can guide treatment because different medications work at different points in that process, and can help in guiding how we what we suggest to you to help with your particular problem, and it is very specific to the person. So what are some of the things we can do if there's a bladder storage problem where things are not able to be stored and it wants to leak out and wants to come out without our controlling it? So we can do behavior modification, pelvic floor therapy, medications can be used if needed, and certain procedures, and we'll walk through these one by one. So what is behavior modification? I think this is the most important thing to start with, of course. Managing when you drink your fluids, it's always a lot easier to go to the restroom and probably less chance of having an accident in the daytime when we're awake. So we may recommend to you to kind of try and drink your fluids earlier in the day so you have time to pee them out and it's not waking you up all night. It's important to start avoiding things that can irritate the bladder and cause it to kind of contract when we don't want it to and cause the urgency to need to pee. Again, alcohol, as was discussed for orthostatic hypotension as well. Spicy food can be irritating. Acidic things like citrus fruits, caffeine, unfortunately sugar. For some people, milk products and tobacco as well can be irritating to the bladder, and sometimes keeping a diary again can help us figure out if some of these products are causing us to have more problems, and then trying to cut them out of our regular diet if possible. I know for me, it would be probably pretty difficult to cut out caffeine. So just keeping a diary to determine if days that I don't drink caffeine versus days that I do, is there actually a difference, can help. Treating constipation is very important, and we'll talk about constipation in a couple of slides to come. But if you think about it, if our intestines and our colon are full of undigested food and stool, that can actually push on the bladder because it's close proximity, and that can also cause us to need to go urinate more frequently, maybe because our bladder volume is not as large because there's something pushing against it. Physical therapy can also help to strengthen some of those muscles that are used in keeping urine in and helping to actually void correctly. And bladder retraining can be done by the physical therapist as well to kind of help us utilize those muscles better that are not working as well due to the impairment in the nerves that are coming down to those muscles. We can also use medications if some of those conservative measures fail. People use anticholinergic medications, things like oxybutynin and beta-3 agonists. These are kind of newer medications, things like miragabon or Mirbetriq is the brand name. We do, as the exclamation mark indicates, we do recommend avoiding anticholinergic medications as much as possible. These are over the counter, for example, things like Benadryl, but different versions, like I said, are used to treat urinary problems because they can cause significant cognitive problems in older adults, especially, but even in younger people. And so we do advise usually people to avoid this type of medication if possible. And some of these newer agents, while some insurances don't cover them as well, are maybe safer options. And then newer procedures like nerve stimulators can help also. Again, we're not going to go into a lot of detail on that. And then botulinum toxin injections. So if you think about if your bladder is contracting too much, the urologist may be able to put botulinum toxin injections to weaken that muscle to prevent it from contracting as much. Or if it's the sphincter is tightening up, they can inject Botox into the sphincter to relax it, to allow you to go more or empty your bladder more without that constriction that you're working against. And then for avoiding dysfunction, again, some of the same things, same behavior modification and pelvic floor therapy that we talked about. The medications are a little bit different. So now we're trying to relax the sphincter because it's too tight. So things like tamsulosin or can be helpful, baclofen to relax that muscle. And then if in males, if there's a hypertrophy or enlargement of the prostate, which again is causing that outlet to be somewhat obstructed, that can also, working on the prostate can sometimes help as well. As I discussed, sacral neuromodulation can help with voiding dysfunction as well, botulinum toxin injections to the sphincter, and then sometimes we need to use intermittent catheterization where you're putting a tube in to get that fluid out that's collecting to prevent an infection. We really don't like indwelling catheters because they are a source of infection themselves. If this thing is constantly sitting in your bladder, bacteria can start living on the plastic and then be constantly seeding your urine and causing frequent infections. So we might move to something called a suprapubic catheter, which is cleaner and goes above this bone here straight into your bladder rather than going from the down up. But all that should be worked on with the urologist if needed. And then this is a topic that a lot of people don't like talking about, but it is very important. We're social creatures. We do have family, we have caregivers. We want to keep that interaction going with our partners. And so sexual dysfunction also is very common in people with multiple system atrophy. It can again be a very early sign of the disease, often occurring before other symptoms and may be treated as an independent feature early rather than as a part of MSA. Men can have erectile dysfunction and problems with ejaculation and difficulty getting orgasms. Women can have vaginal dryness or decreased libido, and again, difficulty with getting orgasms. And there are options for these, and sometimes we do need help from our OB-GYN or urology colleagues to help treat some of these. But if you don't, it's very important to talk to your doctors, and usually your neurologist being the gatekeeper, about problems if they're occurring so that we can help, because if we don't know about it, we really can't help you work through these things. And again, it is an important part of our daily lives. Again, an exclamation point just to keep note, a lot of the medications that are used to treat erectile dysfunction in men, again, can cause pooling of blood in our organs. And so that can worsen the orthostatic hypotension, especially if you stand up quickly after using some of these medications. So we do advise that you take special care standing up or try and lay down for a while after maybe use some of the medications that treat erectile dysfunction in men. So gastrointestinal dysfunction also is very common. This can be difficulty swallowing. There can be abdominal pain and bloating. People can get nausea. There can be delay. Everything slows down in our body, including how things go through our gut. And so there can be delay in emptying of our stomach contents. And all of this slowing can lead to constipation as well. So constipation in MSA, it's a problem with passing stool. We define it really as fewer than 3 stools per week, or difficulty time passing stools, such as you're straining to pass, or you feel like you have an incomplete evacuation, kind of similar to the bladder dysfunction, where you don't get it all out, and so everything is sitting there with all the water constantly being absorbed and getting harder and harder. Again, 80 to 90% of people with MSA have this problem. And the risk is if you wait too long to have a bowel movement, it may itself harden to the point where it's obstructing the outlet now. And then you need to go into the ER to get it manually disimpacted, which is not comfortable. Again, physical examination and history are important. We can keep a diary of our movements. We can use that scale that was shown in the previous slide to define what our stool type is like. And then sometimes in people, there may be other causes of constipation. If all else fails, maybe we need to have our primary care provider look into other common causes of constipation, such as thyroid dysfunction, anemia, and in an older aging population, things like colon cancer, obstructions can cause constipation as well. So how do we treat it? Again, lifestyle modifications and medications. So physical activity is important. That activates everything and makes things move, not just in our body, but also through our gut. It's very important to keep hydrated, and by hydrated, we mean at least 1.5 liters of fluid per day. So, about half a gallon of liquid. Increasing fiber in the diet can help, 20 to 35 grams daily. There are fiber supplements that we can add to our food and water to allow for that increased fiber. Prunes, other things are high in fiber, can also be added to the diet. And then if symptoms are persistent, we often recommend things like Miralax, which is the brand name of something called polyethylene glycol. And the reason is that what this works on, if you all remember your high school biology, or chemistry, it's an osmotic agent. So what that means is, as I mentioned, things are sitting around in the gut longer, all the water is getting absorbed. So how Miralax works is it's not a medication that's being absorbed into your body. It just allows the stool, it prevents the water from being absorbed out of your stool as much. It keeps the water in the stool so it's softer and flows through better. And then you can also use stimulant laxatives like bisacodyl and senna, which are available over the counter. And this is a nod to one of our senior movement disorders neurologist, Kapil Sethi, who has now passed. But he always proposed the Indian style toilet, and I grew up with some of these. It's basically just a hole in the wall, in the floor, compared to a Western style toilet. So what you're doing is you're squatting down. And if you look at the biomechanics of how the gut is positioned, when we're sitting on a Western style toilet, there's a muscle called the puborectalis that is actually causing a constriction in the outflow of our stool. And by squatting down, you relieve that constriction. And so you can buy products now in the market that can sort of convert your Western style toilet more to that squatting position, which opens up the angle and allows easier passage of stool and maybe less strain and development of hemorrhoids and other complications of that. So if lifestyle modifications fail, we sometimes use the help of a gastroenterology colleagues. We can use newer agents, and I prescribe these myself sometimes. Things like linaclotide or Amitiza are newer agents for chronic constipation that do help some people where the simpler treatments have not helped enough. Nausea is also common in MSA. It's important to avoid. The major teaching point here is it's very important to avoid medications that can block dopamine. MSA is a disease that is due to decreased dopamine in the brain. And a lot of the nausea medications, things like Compazine, Reglan, metoclopramide, they all work by blocking dopamine, and we don't want to use those medications. So I'll hand it back to Guillaume.
So I will talk about briefly about thermoregulatory issues in MSA, and let's talk about sweat. Sweat is really the only way, almost the most powerful way that your body can regulate body temperature, right? So it provides a thin layer of water on your skin when you're too hot, and through the process of evaporation, it basically cools your body. And people living with MSA often lose the ability to sweat. Uh, and one of the symptoms is that they cannot cool down their body. So when they go outside, when it's very hot, they have heat intolerance. And one of the manifestation is not necessarily feeling hot. They just don't feel great outside. They feel weaker. They might be dizzy. They might have cramp. And in extreme cases, you can have what we call a heat stroke because your body is unable to lower its temperature. Um, in terms of to advance it. Yeah, so in terms of testing, there is really not a lot of easy way to test sweat function. There are a few laboratory, I think 3 in the US, who can really test your entire body sweat production. And I will walk you through that slide very quickly. You see that purple man in the middle is someone who sweat normally. So the purple is just a powder. So the powder is a yellow powder that we put in the body, and the patient really goes into a oven, like a hot chamber, and the yellow powder turn purple with sweat. So normally, if you're exposed to a very hot environment, your entire body should really sweat. Sweat glands are really distributed all over your body. And in multiple system atrophy, what we see is a lack of sweat. So either a completely global lack of sweat, that's that man on the left side, really like it's completely yellow. There's no part of his body that is sweating. Or we see the right part of the slide, which is only the hands that are typically sweating. The emotional kind of sweat function is preserved. So, when you are stressed or very emotional, your hands might be sweaty, your forehead sometimes is sweaty. So in MSA, that can be preserved while the rest of the sweating regulation is abnormal. We don't have good treatment to restore sweat function. What we want to avoid is heat stroke. That can be extremely dangerous and it can actually lead to death. So the idea is to avoid the trigger, right? So avoid exposure to heat, staying in a cool place, maintain good hydration, mimic the sweat. So you may have seen those spray fans. So that's a spray bottle with a fan attached to it. And you can spray your body. And what it does, it creates a thin layers of water on your body that mimics sweat. And some people living with MSA found that technique really helpful when they have to go outside, to go to a grocery store, do something with the family. They use the spray fan in the summer. There are some cooling vests that we can have. It's basically a vest with maybe ice pack or cooling devices. And the idea is to really avoid any tight clothes, tight or warm clothes that could increase the risk of overeating. And the last thing I wanted to talk about is the vasomotor dysfunction in MSA. So vasomotor means that there is issue with regulation of very, very small blood vessel in your extremities, in the hands and in the feet. And there is a sign called cold hand and feet, which is, I think, still a supportive feature to make the diagnosis of MSA. It's often that there is discoloration, red or even purple discoloration of the hand and feet in people living with MSA. And it's really a reflection of impairment of microcirculation in the extremities. In terms of temperature, it's often that people living with MSA tell us, my hands are always freezing, always cold. My feet are always freezing and cold. And this is something that we can see in multiple system atrophy. Now we have about 10 minutes for questions. So hopefully that was helpful for you.
Thank you both so much for that presentation. We do have some questions from folks. So we will get to as many of those as we can here in the next few minutes. So our first question is going to be, is supine hypertension always accompanying orthostatic hypotension?
Yeah, that is a very good question. And it's in about 50% of patients who have orthostatic hypertension, you will see supine hypertension. That is the number that is quoted in the literature. That is not a number specific to multiple system atrophy. It's mostly a number that is based on patients who also have other forms of autonomic failure, Parkinson's disease, for example. But it is frequent, but I would say around half to just above half of patients who have OH will have supine hypertension.
Thank you. And then kind of along those same lines, is there anything you would say that patients can do for that supine hypertension? Someone is saying they're dealing with that after starting the midodrine and the levodopa.
Yeah, so very good question, right? And I think it's important to recognize that aspect of blood pressure regulation, right? So supine hypertension is by as the name implies, is hypertension supine, right? So the first thing is the medication that you use to help your low blood pressure are used during the day. So that means that during the day, if you have supine hypertension, you should not lay down. Right, so that's number one. If you need to rest, you can sit, you can go in a recliner, but really not lay down because your blood pressure might really be too high then. Now, if you have supine hypertension, which is typically more at night, because people lay down in bed to rest and to sleep, then we raise the head of the bed, as we discussed in the slide. Sometimes we tell the patient to eat a snack before bedtime. Remember, when you eat something, it's going to drop the blood pressure because there's shunting of blood in the belly for digestion. There have been some cases where, typically we don't recommend to drink alcohol, but if someone drinks alcohol, if there's a time of the day where it's probably safer, would be at bedtime, right, at night, because it's going to lower the blood pressure. And sometimes it's very important to tell your physicians about that problem, because we might have to treat the supine hypertension with medication, right? So we might have to use medication to lower blood pressure at night, which will not affect the blood pressure during the day, and to raise blood pressure during the day, which will not affect your blood pressure at night. But that means you cannot lay down during the day. We go back to the take-home message.
Thank you. Okay, another question for you is going to be, do any of these symptoms, worsen as the disease progresses, or is this kind of a more constant symptom that you see with MSA?
So I can start on that. So yes, and unfortunately, these symptoms do kind of occur in different people at different times, but they do also worsen along a scale. So as an example of the urinary dysfunction, people may start by having a little bit of increased frequency in urination, and then that urge develops and they can't get to the bathroom in time, and then they start having incontinence or inability to, control it at all. And so that's kind of the spectrum of worsening of those symptoms. And similarly with orthostatic hypotension, Dr. Lamotte defined it as a drop of 20 on your systolic blood pressure, but in MSA, as many of you unfortunately may be experiencing, that blood pressure drop can get worse and worse as the disease progresses, and you can get very low blood pressures, and that can be that severity increase where now, maybe you were dropping from 130 to 110, but now you're dropping from 130 to 90. And so that progression over time can make the symptoms more severe and require more ways to manage them. As Dr. Lamotte suggested, like for the orthostatic hypertension, sometimes we do what we're taught not to do in medical school, where now we're adding a medicine to raise blood pressure, we're adding a medicine to lower blood pressure, but we're trying to get you in kind of a band so that you're not fluctuating up and down as much as can be seen in a lot of patients with MSA with very highs and very, very lows as well, even in the same day.
Awesome. Thank you. Someone else mentioned that their husband is having issues with urinary retention and UTIs and is asking if you have any suggestions for finding a urologist with experience managing MSA or Parkinsonian disorders in general, because they're not really having luck finding one.
That's a harder one. I think you need maybe hopefully if you have an MSA center nearby. I know that we kind of have established certain providers that have more of an interest in neurologic disorders, and we tend to refer our patients to those providers. In Arkansas, that's difficult because again, it's a rural state, so a lot of our patients end up having to come down to the medical center, even if they have to drive 2 to 3 hours to see someone who's trained in Botox, for example, and knows how to do the urodynamic studies correctly. So yeah, it can be a problem. I think, as you said, the first resources is your MSA COE leads. I don't know if Mission MSA is collecting providers for other disorders other than just the neurologists, but that may be something that we should start doing on the website as well. And then, calling around maybe sometimes and just asking, you know, does, because not all urologists do these. So just asking before you schedule that appointment, do you all do urodynamic studies in your office, and are your doctors trained to do Botox, so that you're not wasting time going to someone who's not able to do the things that are needed. Everybody can prescribe medications, right? But not everybody does the more advanced therapies.
Thank you. Someone else asked, so if you're checking your blood pressure at home on a regular basis, is that sufficient to determine whether you're dealing with orthostatic hypotension or not?
Yes, it is, but I would say we as neurologists, we treat the patient. We don't treat numbers, right? So, and the last thing I want is for someone to have his or her life revolving around checking blood pressure. So I think that's important to convey. But yes, blood pressure logs can be very helpful. But doing it, every day, all the time, multiple times a day for several months is really helpful for us. But for a short period of time, when we change medication, introduce medication, if we want to detect supine hypertension, those can be helpful. And I would say home blood pressure measurement are typically pretty accurate now, especially with the new machine that we have. So I would say yes, but we are going to treat the symptoms, not the numbers. So that's a discussion to have with your neurologist.
Yeah, and just to add to that, I don't know if you do this, Dr. Lamotte, but sometimes the question comes up often, is levodopa causing me to have a drop in blood pressure? And so sometimes I will ask patients to check their blood pressure in the morning before they take their levodopa dose, and then 30 to 40 minutes later, but again, for a regulated period of, 3 to 4 days before they come into the clinic visit, not every day, every hour.
Yeah, good point.
Thank you. We've got time for maybe just one or two more questions here, but I want to ask, do you also observe pupil dysfunctions with relevance for everyday functioning like vision as a sign of autonomic dysfunction?
So the answer is yes. If you look at the pupillary function, so your pupils should really become smaller, constrict with light exposure, and dilate in the dark. And it's been shown that in people living with MSA, the speed and how much it changes in diameters is not normal. However, it is difficult to know if it has an impact, clinically on everyday life. A lot of patients report light sensitivity, which might be to some extent related to difficulty with pupillary dilation and constriction as well. So I suspect it's contributing to some of the symptoms of difficulty with reading, light sensitivity, difficulty with adapting, going to a dark room, for example, although it's relatively understudied in multiple system atrophy, mostly because it is not a lot of centers have the equipment, the necessary equipment to do good studies of pupillary function, and a lot of medication will affect pupillary function.
Thank you. I want to ask just one more question just to kind of wrap things up here. So, obviously a lot of the symptoms that you guys have talked about today um, could be related to issues other than MSA. And so what would you say to someone who is dealing with these symptoms of autonomic dysfunction, but is not sure how to kind of take a first step toward determining whether they're dealing with MSA or something else?
I think the most important thing is to talk to your physician, whoever is your kind of provider, even if you don't, let's say someone is not established with a neurologist yet, talk to your primary care about those symptoms. And as physician, we are kind of trained in somewhat pattern recognition, and that's where we if we see issues with multiple autonomic function, we measure blood pressure, there is orthostatic hypotension. And then there is a history of constipation that is more severe than what we would expect. And there is maybe some urinary symptoms. Those are big red flag that should, prompt a pretty quick referral to a neurologist and maybe someone really specialized in, let's say multiple system atrophy. So it's really, we are a team with the patient. We learn from the patient learn from us, and we really work together. So I would say really an open dialogue with a provider is really a good way to start.
Absolutely. Thank you. Well, thank you both so much for that presentation and for answering those questions. I know we didn't have time to get to everyone's, but um, if there are ever any questions we can answer, please send us an email at info@missionmsa.org, and you can find that on our website. And we'll do our absolute best to put you in touch with resources. Would also recommend checking out the resource library on our website for other webinars and resources for MSA. Thank you again to both of our speakers. That was such a wonderful presentation, and we're so thankful that you were here.
Thank you.
You.
If everyone attending the webinar wouldn't mind hanging on for just 1 second, I am going to send out a really brief 2-question survey just to get your feedback on today's webinar. It helps us to plan for future webinars. We do these monthly, and would just love your feedback. So I'm going to send that out right now, and then once you fill that out, feel free to be on your way. Thanks so much for being here.